Thank you very much, Mr. Chairman, to kind introduction. I'm Sang Hyun Ihm from KDIGO University of Korea. I would like to thank especially organized committee of GWICC. I'm honored to be here and give you a presentation today. Today's topic is practical management hypertension in Korean after sprint trial. These are content. We can observe J-curve phenomenon in many clinical trials. So, lowering BPs reduce the incidence of cardiovascular morbidity and mortality. However, lowering BP below a certain point result paradoxically in increase the incidence of cardiovascular event. This J-curve phenomenon has increased the target BP of recent guidelines. This slide shows the target BP of recent guidelines. So especially ESH, ESC guideline recommend the target BP of most hypertensive patients is below 140, 90 millimeter mercury, except diabetes, CKD with proteinuria, and elderly patient. According to previous meta-analysis data, from 115, 75 millimeter mercury, each increment in systolic BP of 20 millimeter mercury or diastolic BP of 10 millimeter mercury doubled the increase of risk for cardiovascular event. In addition, as you know, lowering BP can reduce rapidly cardiovascular event. Even a 2 millimeter mercury decrease in mean systolic BP results in approximately 7% risk reduction of ischemic heart disease mortality and 10% risk reduction of stroke mortality. This slide shows the meta-analysis data. This meta-analysis study released in November 2015. This study showed the effect of intensive BP lowering on cardiovascular and renal outcomes. This meta-analysis data included 19 trials, including 45,000 participants. Mean follow-up was 3.8 years, and 2,500 major cardiovascular events were recorded. Patients in the more intensive BP lowering group was mean BP level of 133, 76 millimeter mercury. Patients in the less intensive BP lowering group was mean BP of 140, 81 millimeter mercury. This slide shows the effect of intensive BP lowering on major cardiovascular event. As you can see, intensive BP lowering group achieved 14% risk reduction for major cardiovascular event, MI, stroke, heart failure, or cardiovascular death separate and combined. This slide shows the adverse event. As you can see, severe hypertension, although severe hypertension occurred more frequently in more intensive group, but there was no significant difference of adverse event between two groups. This is the conclusion of this meta-analysis data. Intensive BP lowering provided greater vascular protection than standard regimen. In high-risk patients, there are additional benefits from more intensive BP lowering. Existing clinical guidelines should be revised accordingly to recommend more intensive BP lowering treatment in high-risk patients. Eventually, sprint trial announced in November 2015. As you know, this randomized trial compared intensive BP lowering group goal SBP below 120 millimeter mercury against the standard treatment group goal SBP below 140 millimeter mercury. This is major inclusion criteria. At least 50-year-old, systolic BP 130, 180 millimeter mercury, additional cardiovascular disease risk, including elderly patients. This is a major exclusion criteria: stroke, diabetes, congestive heart failure with symptom or ejection fraction less than 35%, about proteinuria, and CKD with significant reduction of eGFR. As you know, SPRINT trial enrolled total 9361 patients. So 78 patients was assigned to intensive treatment group, and 83 patients was assigned to standard treatment group. The primary outcome of this study was the first occurrence of cardiovascular disease composite, MI, non-MI acute coronary syndrome, stroke, acute compensated heart failure, cardiovascular disease death. This is achieved BP reduction. So at 1 year, mean systolic BP was 121.4 millimeter mercury in intensive treatment group, and 136.2 millimeter mercury in the standard treatment group. The difference between two groups was 14.8 millimeter mercury. During follow-up, average systolic BP was 121.5 millimeter mercury in intensive treatment group and 134.6 millimeter mercury in the standard treatment group. As you know, this study was stopped early after median follow-up 3.26 years, owing to significant risk reduction of primary cardiovascular outcome and death. So as you can see, intensive treatment group achieved 25% risk reduction primary outcome and 27% risk reduction of death from any cause. If you look at the primary and secondary outcome in detail, especially heart failure, death from cardiovascular cause, and primary outcome of death in the intensive treatment group showed a significant benefit. However, the MI, acute coronary syndrome, and stroke in the intensive treatment group show no significant benefit. Among the participants with CKD at baseline, there was no significant difference between two groups in the composite renal outcome. However, among the participants without CKD at baseline, the incidence of reduction in estimated GFR was higher in the intensive treatment group than standard treatment group. This slide shows the serious adverse event. As you can see, hypertension, syncope, injury, syncope, and electrolyte abnormality, acute kidney syndrome, or acute renal failure occurred more frequently in the intensive treatment group, but there was no significant difference of serious adverse event between two groups. This is the summary and conclusion of SPRINT trial. Participants were US adult at risk 50-year-old with hypertension and additional risk for CVD. And incidence of primary composite outcome was 25% lower in intensive compared to standard group, and all-cause mortality reduced by 27%. In participants without CKD at baseline, incidence of eGFR reduction was 30% and over, more common in intensive treatment group. Overall benefit of more intensive BP lowering exceeded the potential for harm. However, there are several issues of SPRINT trial. First of all, the BP measurement method. Unconventional methodology used to measure BP with an automated device and the patient being quiet and isolated in an unattended room. Second is SPRINT eligible population. As you know, SPRINT study result applied to only sprint-eligible population, which was only 30% of the total population receiving antihypertensive treatment. Lastly, balance between efficacy and safety. Although absolute risk reduction of cardiovascular event, the risk of adverse event was higher with the intensive treatment group than with the standard treatment group. This slide shows the BP measurement in sprint trial. They used look at this device, Omron Ham 907. They using AOBP. Blood pressure reading were conducted in a unique manner that is probably not the standard in our office. Patients were asked to sit quietly for 5 minutes before BP reading were measured by automated unit. 3 readings were obtained over several minutes with no coordination in the room. Especially Canadian guideline included the automated office BP, unattended AOBP for office BP measurement method. Especially the AOBP, as you know, AOBP was proposed by Canadian researchers, and this method was widely used in Canada. This AOBP minimized the white coat effect. They recommend the automated office BP measurement is the preferred method of performing in office BP measurement. When using AOBP, a displayed mean SBP was 135 millimeter mercury and over, or DBP of 85 millimeter mercury and over is high. This is a slide showing the comparison of BP reading obtained in clinical setting using a different method of BP measurement. A routine manual office BP, automated OPBP, and awaked ambulatory BP. There are 3 different studies. As you can see, the difference between routine manual office BP and automated OPBP was up to 10 to 20 millimeter mercury. It means the less than 120 millimeter mercury by unattended AOBP from the sprint trial may be equivalent to around 140 millimeter mercury under usual clinical practice. When sprint study announced at the time, sprint has been viewed as a landmark trial serving to establish more aggressive approach to BP measurement. However, the application of sprint in the real world has been much more limited and modest due to the already mentioned several issues of sprint study. There was no significant change. However, if tolerable, we can try to attempt lower BP with careful monitoring. In addition, sprint study may encourage widening the use of AOBP. The target BP in high-risk patients with hypertension, that is the sprint-eligible subject, should be below 120 millimeter mercury using only AOBP. And sprint not applicable patient for hypertension patient with other conditions should not be changed. Especially CKD patient with albuminuria should not be changed. It should be yet below 130, 80 millimeter mercury. Since the AOBP is not yet generally available in clinical practice, the definition of hypertension should remain BPs of 140, 90 millimeter mercury and over. The target BP should remain to lower BP in most hypertensive patients to below 140, 90 millimeter mercury. I would like to summarize my talk. The sprint trial clearly showed that lower is better. A goal SBP of less than 120 millimeter mercury measured by only AOBP can be beneficial in patients with hypertension, with high-risk patients, including patients on advanced age with diabetes. And sprint BP target are well tolerated by all the patients, relatively fit, with good outcomes. For the study, I needed in patient population that were excluded from the sprint trial, such as diabetes patient, to determine the hypertensive population that can tolerate and benefit from lowering SBP target to 120 millimeter mercury. In addition, we need standardization of BP measurement technique and method in clinical trial. This schematic figure shows the potential influence of a sprint study in BP goals in daily clinical practice. Entry criteria in sprint trial, yes or no, is target population 20, 30%, 76, 80%. If it answer S, the target BP below 120 millimeter mercury using only AOBP. Finally, since AOBP is not yet generally available in clinical practice, the definition of hypertension should remain BPs of 140, 90 millimeter mercury and over. And AOBP will be the preferred method of performing in office BP soon. The target BP should remain to lower BP in most hypertension patients to less than 140, 90 millimeter mercury. In case of higher cardiovascular risk patient, that is the sprint eligible population, target BP should be below 120 millimeter mercury using AOBP. And together, if you're using AOBP, target BP should be below around 130 millimeter mercury. Other including DM, CKD, over to proteinuria, target BP should not be changed. However, we keep in mind that we should take into account the balance between benefit and risk for the practice of personalized, individualized medicine. If tolerated well, one could attempt to go lower incrementally with careful monitoring. Finally, I would talk to you. We always treat the patient, not blood pressure, figure, or value. Thank you very much for your attention.